in the advent of endoscopy. I've seen its evolution, and I've been a part of its change. And as they say, things change, but the only thing that is constant itself is change. And I have seen that there are disputes and fights and, animalistic behavior in endoscopy. The MIS people with the microendoscope people saying we are the best, it is gold standard. The transforaminal people saying we have a very small hole and we are the best. The interlaminar people saying no, ours is a single hole trajectory and we are really minimal invasive and we are the best. And then came along the evolution of UBE. There is unilateral biportal endoscopy. And again, that same criticism, no, you're taking 2 cuts on the back of 5 millimeters and therefore you are causing more damage.
Recording in progress.
Ask you to put aside these petty views and let us evolve into a world of consensus where we learn to respect each other, where we learn to appreciate the opinion of each other, and rather than have our own opinion about everything. So we must move into a world of consensus. So my dictum stands is do what suits you best. If you are an excellent tubular surgeon with a microscope, please stick to it. Nobody says you change. There is no compulsion on change. I see the world evolving. I see the new breed coming in, aggressive, wanting to know endoscopy, doing endoscopy, and there is a need for change. But then again, like I said, do what suits you best. So that is my dictum. The frequent dilemmas that I come from colleagues that come to me is, what is the best form of MIS endoscopy? I say the best form of MIS endoscopy is what suits you best. If you are happy with monoportal, please stick to monoportal. You call it full endoscopy. There are various terminologies. AO has brought in their own chart of terminologies, and it's basically a mess. But the whole point is, do what suits you best. What should I learn? That is the question that is next asked to me. Should I learn transforaminal? Should I learn monoportal? Should I learn biportal? I say learn everything. I say you should learn open spine surgery. You should learn tubular. You should learn to use a microscope. You should learn to use a transforaminal scopy, monoportal scopy, biportal scopy. I do everything. What suits me best in a particular situation? That is my God. That is exactly the way I have evolved, and that's why I suggest that every student should not be dogmatic about a particular approach, but rather learn to adapt and adjust, because you're eventually there to deliver a result to a patient. Your core existence depends upon your patient. So therefore, try to do your best in whatever suits you the best. UB, how do I do it? I've written this book. This book has been written by me explaining in fine nuances, fine nuances, how you will actually even hold your scope. What will you see? Why do you cut? Why do you burr? At what level do you do it? It means I have written it from my heart, the way I would do a surgery. That is the way I've written this book. Therefore, the book has very little of references from outside. I don't think I'd have even 20 references in my bibliography, because it's all about what I do, how I do it, how I evolved this technique in India simultaneously as it was evolving in Korea. And obviously, it initially came from UAE, from Dr. Abdul Ghaffar, who had presented his paper in NAS and subsequently stopped doing it. Then the Koreans with Dr. Yoon Jinwa, Dr. Sun Kyu Song, and their team, they developed UB in Korea. I had a brief interaction with one doctor, Dr. Chiu Long Park, and that time he had just conceptually spoken to me, Malcolm, we are planning something like this in Korea, and that triggered me. And that time I was a professor with MGM University, and he said, why not we develop something similar and work on similar lines, and let's see what is the outcome of it. And believe me, the outcome was shocking, amazing. And question is, why do I do it? Now, in life, why do we change? Why do we adapt? In management, there is a terminology known as deficiency gap. Whenever you come across something that you feel is inadequate, and you feel that I need change, I need to do better, I need a better result, that is what drives you to scale up, to change, or to adapt. So my adaptation to UB started 8 years ago. And I was 52 years of age then. And today I'm 60. I had my birthday yesterday, day before yesterday. So it's been a late change in life, but it's been an amazing ride. It's been an amazing journey. And today I'm going to share that journey with you. So today, let us set this talk spectrum for today. What are we going to talk about? We're going to talk about what is UB, what is the instrumentations, the basic roles of fluids in endoscopy, and we're going to talk from UB, from cervical to lumbar, approaches, techniques, mixed adaptabilities. And I hope you enjoy this talk. I mean, I've tried to move away from that standard talk, showing me removing 10 discs and saying, okay, I did a great discectomy. That's just a small part of what UB is. UB is something much more. So today we're going to talk about that. So I hope you really enjoy this talk. And we now move to the next talk. That is the cutting tools in UB. And let me just enlarge it and let me start going to the first slide and let me go to the play part of it. What is UB? UB is basically a surgery under irrigation with wide access. See, the words are very specific, with wide access to both sides of the neural tube. You are not confined, you're not struggling. You don't have to adjust a tube, adjust the angle of your scope. You don't have to struggle to rotate a patient to be able to see on the contra side, though you may be very good at it. But the fact remains that it gives you beautiful access on both sides of the neural tube. You can use all standard spine instruments. It does not use a very expensive scope. You can use a normal arthroscope. It uses the burr that we and orthopedic surgeons use, and even you neurosurgeons use. It uses one special instrument, that is the plasma radiofrequency device, which is a stepped up bipolar device. And apart from that, there are a few very small specialized tools, and that gets you going with UB spine surgery. Now, why? Why UB? Excellent view due to magnification, but that is true with all forms of endoscopy. 4-root visualization. I am able to see both the exiting roots and the traversing roots where they exit. Now that is unique. To be able to go below the lamina, to be able to go into the axilla, to be able to check a root going right out into the foramen, then check the dural tube, then check the traversing root, and then check the traversing root going out. At the end of your decompression, to be able to see 4 roots is a wonderful feeling for a spine surgeon. You can access the disc from both sides. So if you have a central large disc bulge and you feel there are a few fragments you want to excise from that side, few from this side, fine, you can do it both ways. You can treat all forms of stenosis. We're going to speak today more on foraminal because central, lateral are standard. Fusion. Now, fusion was something that in our initial pursuit of endoscopy, I remember giving my first lecture in 2017 on facet sparing transcambin transforaminal fusion. And we had started using the transforaminal pathway to do fusion. But with the facet sparing or even partial facetectomy being done, there was always a limit to the size of the cage that we could put in. So that was again a deficiency gap in this fusion spectrum. To overcome that, the question was, what should I adapt to? If I want to use a large cage, then what should I adapt to? If I want the cage to be placed in the center, what should I adapt to? So fusion became a part and parcel of UB endoscopic spine surgery. So it opened up a big vista. It opened up a big avenue. And then obviously we are always struggling with migrations, especially upward migration, hidden zone of Macnab, high lumbar levels. You need to cut through the entire lamina to reach a fragment to be parallel to a pedicle. So what do you do in such circumstances? So UB started giving us certain very beautiful answers, which actually I've even published. It's been accepted for publication. We'll be talking about it in a short while. Basic concept is, yes, I'm using 2 ports. I take 2 small skin cuts. I probe with a blunt probe the depth of the fat and the fascia. I see the probe, then I take 5 millimeters extra on the probe and I cut the fascia only to that depth. This cutting of the fascia to that depth ensures that the entire paraspinal mass is not disturbed. Everything beyond that is just systematic dilatation. So whether it is 2 cuts or whether it is 1 cut, that's all hogwash. It really makes no sense. I mean, it's like, wives bickering over, women bickering over something. I mean, I'm sorry, I should not be sexist in any way, but we don't want the bickering part of it. So let's just keep that out. Now you have a scopic portal and you have a walking portal or a working portal, whatever terminology you wish to use. Originally, initially I used to use the semitubular retractor to have an egress channel. Now, what is the difference between monoportal, transforaminal, and biportal in fluids? We will be taking a little later in this topic itself, so I won't waste time over here. The concept of UB starts with the point that I have to triangulate. Now, the scope is quite like a human skull. It has a lens in the front. I can't see what's behind my skull. Maybe you can see that there's a mask hung up on the wall there, but if I were to look in front, I can't see it. So obviously, the working instrument has to come in front of the scope. For it to come to front of the scope, you have to triangulate at a depth. Now, in a very fat patient, I understand triangulation can be a little tricky. But with a little bit of practice and with a little bit of tricks that I have given in my book, if you follow that, it becomes very easy to triangulate. What you need to do is play some good music, be very patient, be very calm, set small goals for yourself, practice on a cadaver if you can, and then start endoscopy. I remember my first UB surgery. I spent 2.5 hours searching for the probe, couldn't find it, was frustrated. I threw my instruments on the floor, picked up the knife, and did an open spine surgery. But then I said, no, Malcolm, I need to adapt. I need to change. I need to bring patience into my work. And then came the practice on the porcine cadaver, human cadaver. And slowly, triangulation becomes very, very easy now. It hardly takes a few seconds. But the point of triangulation is that you are stripping, elevating, and shifting the muscle mass off the lamina. You are not cutting anything. So you are not at all using a kerrison or a grasper or a punch to bite into any muscle, which unfortunately is required most of the times when you're doing either a Destandau procedure or you're doing a tubular procedure, because muscle tends to come in from below the tube, or if you're even doing a monoportal procedure. So frankly speaking, it is less traumatic. Now, where does this fluid go? Everybody asked me this very question. And actually, when I was first asked this question, it came to me as a shock. Somebody told me, doctor, you have used 20 liters of saline during the surgery. Has everything come out? Has the fluid gone in the patient? Can the patient go into a fluid overload? That set me thinking. Okay, there is some sensible question this person asked, and I am unable to answer it. I mean, this is my initial years. So then came the thinking. So the thinking is this way, and which I can show you here. Well, we have a posterior thoracolumbar fascia and we have a middle thoracolumbar fascia. The MTFL separates the quadratus lumborum and the psoas and the retroperitoneal space from the back. All the fluid that you pour in is like pouring in a cup. What will flow out on the back. So when you're putting fluid from here, it comes out from here. You are working within a chamber. There is no question of fluid extravasating into the retroperitoneal space and thereby causing any serious injury to the patient. Unless obviously in a procedure like para-UB, you are too far lateral and you tear the the middle thoracolumbar fascia, which you should not be doing. So basically whatever fluid goes in is going to come out. That is the dictum. Basic theater setup is general anesthesia is preferred. Patient is prone in position. We have a UB specific drape for irrigation collection. And you should have the ability of a C-arm to sweep from below in AP and lateral positions. Why am I not? Just 1 second. Why am I stuck? Okay. Now, what are the additional instruments that you require? The additional non-spinal instruments that you require is one is you require a plasma for tissue ablation and coagulation. You require a small burr for shaving. I've shown the normal orthopedic burr, but you can use a neurodrill. And you can use a 0 or a 30-degree scope. Now, before I go there, let us just speak about the 0-degree and 30-degree scopes in a very short, brief analysis. If I were to keep my hand like this, you can see my hand nicely, right? Now a 0-degree scope, whichever way you rotate, is going to show you the same view. But if I were to show you a 30-degree scope, this is 0 degrees, this is 30 degrees, and then I keep rotating it, it is covering a wider spectrum of coverage. But a 30-degree scope has a disadvantage. The distal horizons appear very flat. So when you're seeing the opposite facet, it appears flat. There is loss of curvature of the spinal cord. So you don't know at what depth you have gone onto the opposite side. So how do you counter that? You just hold the scope and rotate the camera head cranially to see a valley view. You see a tunnel view. And you can see the depth perception very nicely. You can continue working in that manner, or you can readjust your scope, align it with your camera head, and continue working with a flat perception. Now, why a 30-degree scope is favorable? Why my book has been written with a 30-degree scope is because when I want to do fusion, when I want to do para-UB, when I want to do any foraminal IPSI cutting, when I want to go underneath the foramen and cut the roof of the foramen, I want to cut the SAP and IAP by sitting down and looking up. How do I do it? I need a scope that is not seeing straight, but that is seeing upwards. So I need the 30-degree upward view. Therefore, if I'm going to use the 30-degree scope in some indications, and then use a 0-degree scope in some indications, every time my visual acuity and my mental memory of an image has to switch. I'm likely to create mistakes. So I prefer to teach my students to learn with a 30-degree scope, right from day one, persist with it, get over that flatness of field view, so that later on, they are very comfortable in whatever surgery they do with the scope. So that's my perspective, that's my take. Need not be the agreement with everyone, but that's the way I teach my students, and that's the way I flourish in my UB practice. Now, fluids in UB. The fluid that we use in UB basically is saline. It's a constant irrigation, so therefore it washes away the blood and allows you to see all the structures in a very beautiful, classical, delineated manner. Clear visualization. We set the pressure around 30-35 degrees because the epidural venous pressure is somewhere around 15 degrees, maybe sometimes even lower. It's supposed to be negative, but when you open up, they say it's a little positive. So therefore it's around 15 to 20, and we use a pressure of around 30 to 35. So it makes sure that the oozing that comes from the bone or from the phlegm or from the epidural vessels tamps down, doesn't disappear, but tamps down. Fluids in UB are governed by two laws, the Pascal's law and the Bernoulli's principle. Now, what are these? Okay, I have kept a link here in the talk, so you can go to the talk and you can even see it on the YouTube, but I'll explain to you in brief. Now you see here, what do you see? You see an IV bottle. It has a cross-sectional area on which gravity and pressure is acting. But that bottle is big, but the tube, if you see the cross-sectional area of the tube, that is very small. So you will say that the pressure in the tube is less. How does it lift up the muscles on the back and allows me to work? This is my scope. Coming from here, this is my working instrument. Now it works on the principle of Pascal's law. Now what is Pascal's law? I'm sure each one of you has had a flat tire in your life. And you need to get out of the car, bring out a jack, and start winding a jack, lift the car up the road, get the tire out, put in a new tire, put on the nuts, drive to the nearest mechanic, have the older tire sorted out, and then go about your work. It works on the principles of hydraulics. So what is there? When you pressurize a small chamber, but this chamber is fluidly connected to a larger chamber, then the pressure in P1 is equal to the pressure in P2. So this is P1, this is P2. But the area of A1, that is this area over here, is 10 times smaller than this area A2. So therefore, ipsilaterally, ipsifactorally, whatever, I forget the word. But what I'm trying to stress upon is that the pressure of force of P1 on A1 is equal to the force of F2 on A2. So therefore, this force, a small fluid force in a contained chamber that is transmitted by your jack, can lift up a huge car. Now, this is the same principle that we are employing over here. We are using the same principle, small tubing, pressurized by gravity, one hand above the human head. And why I go by this standard sizing is, it's simple. A tall guy needs to adjust the IV stand taller, a short guy needs to adjust it shorter. The surgeon must decide what his forearm length above his head. That's a very standard way of measuring. I will not go into 50 centimeter, 55 centimeter, 60 centimeter, because that's crazy. Let's just stick to a standard measurement technique. But this transmits the force through the Pascal's law to lift up the paraspinal muscles and allows you a clear visualization of the spinal lamina, interlaminar space. This second principle that is very, very important in fluids and endoscopy is the Bernoulli's principle. Now, what is the Bernoulli's principle? If fluid is coming from the scopic portal at a particular speed, when it reaches into a chamber of adequate size, its flow rate drops and pressure builds up. As the pressure builds up, all the bleeding small vasculature stops bleeding, and you have a crystal clear field of view. But if the chamber is of a small size, then it becomes like a tube, it becomes like a pipe. Fluid is flowing in from one end and flowing out from the other end, not dropping speed, not building up pressure, and as a matter of fact, drawing blood from the vessels, from the muscle, from the bone. And you have a disturbed bloody vision. So the first thing that you should realize that when I am not having a clear view, maybe my chamber is not of adequate size. So if you remember these basic principles, you will understand much about UB. There is much more over there. There is the non-linear relationship between fluid and flow, and why UB is better than monoportal, because in monoportal transforaminal, what happens? Fluid goes in through the scope, comes out through the scope. So there is no question of expansion. In UB, what happens is, supposing I'm pushing in fluid from here, in below the muscle chamber, and as it comes out through the other cut, if I increase this flow, this chamber tube size can expand and allow for excess fluid to pass through without significantly building up pressure here. But in monoportal or in transforaminal, if fluid is coming in through the scope and coming out through the scope, there is no room for expansion. And then when you introduce a large instrument to take a bite, you are suddenly and explosively increasing the pressure inside. So there is no scope for adjustment. And that is why many monoportal surgeons do suffer from adverse problems occurring to their patients, which is very, very, very rare in a UB surgeon's case. So, but these finer understandings, they are in the book, so I can't go too much into that. We have a lot to talk about. Let's talk about plasma. That is the other specialized instrument. Now, what does plasma do? It is basically a biportal current, and it also produces the same heat of around 70 degrees if you use it at a high power. But what does it do? It dissolves the O and OH ion in the human cell, and it causes the cell to disappear. So therefore, you can use it for flaval thinning, stripping, disappearing of tissues prior to cutting it. So it's a great advantage in a patient of stenosis. When I've got severe thickening of the phlegm, and rather than punching through the phlegm, I can thin out the phlegm. I can strip the phlegm, make parts of it disappear, make it thinner, and then gently cut it out. So that is the advantage. This was actually brought in ENT for tonsillar surgery, and it was used in a procedure known as scoblation. We have used the same thing in spine. We use the probe at lower temperatures of 40 degrees and lower by keeping the settings low, and thereby I can use it on the neural tissues at maximum. Occasionally I may see slight shrinking of the dura, but beyond that, even if I walk it on the nerve, nothing happens to the patient. Patient may sometimes jerk his leg, but beyond that, believe me, nothing. But it helps in removal of tissue, control of bleeding, and thermal coagulation ablation. Let's put it this way. There are various wands to use. There is one, my favorite is the 90-degree wand. Why the 90-degree wand? Because I can push it deep. I can control its firing surface towards bone, making sure I'm not hitting any neural tissue. And I can control bleeding from bone. You have a reverse 70 degrees, which I use in para-UB, curved, which I use for tangential cutting of a disc, hard disc, to bring down a traversing root. Ball tip is for crucial cervical and axillary work. Now, what do we use? We use a set of 6 dilators. They start from 7 mm, 9, 11, 13, and 15. Now, as your expertise grows, the size of the dilator keeps on dropping. Of late, I use only a 9 mm dilator. But the skin cut is only a 5 mm. The skin is stretched out. You keep the dilators initially for some time because they act like a tamponade. They prevent bleeding from occurring. And when you introduce your scopic portal, it can feel the tubes and it can slide down and triangulate very easily. So it's like finding an elephant in a room rather than struggling to find a small mouse in a room. So that's how all these tricks have been and tips have been explained in the book. You are most welcome to go through it. But these are the dilators that we use. We do not use a guide wire. You don't need any guide wire for localization. No question of accidental perforation of the phlegm, no question of accidentally puncturing the dura. Kerrison punches. You can use your standard punches. Since I do a lot of endoscopic work, I prefer to use rotating punches, rotating kerrisons, curved foraminotomes. You can develop that in your arsenal as you go along. We have simple root retractors. The way you use your root retractors, one is a 4 mm, one is a 10 mm size. The 10 mm size is when I want to introduce a cage for protection of the dura, but even that technique now I've refined. Nowadays, I don't do my fusion surgeries by removing the phlegm. I keep the phlegm intact. After I put in the cage, there is auto separation of the phlegm. And subsequently, I do the flavectomy as the last step of the surgery. Therefore, I don't have bleeding from the epidural tissues at all. So I introduce my cage in an extra flaval scenario. There's an instrument, Indian knife, my Korean friends, they love the Americans. They all have American names. And I don't know who had the presence of mind to name this stabbing instrument as an Indian knife, but it's called as an Indian knife, not referring to Indians. It refers to the American Indians. Chisels. Yeah, you need chisels. You don't use osteotomes. We use a chisel. Chisel has one curved surface and one straight surface. When you want a straight cut, you keep the straight surface on bone. When you want a curved cut and you want to, throw a piece of bone onto the flavum while you're cutting the IAP or something, use the curved side. So you can use both sides of this whole thing. Okay. Curettes, yes, they are a man's best friend, especially when you are inside the disc, your scope is inside the disc. You can see and remove every millimeter of cartilage from where you want it to be removed. You are not blind by just using rotary shavers, because believe me, you use a rotary shaver in a young guy and then you put in a scope in his disc and you will see so much of cartilage there. Very little of really raw bone. And that is one of the reasons why we have a lot of failure in fusion surgeries. Here you can actually go and scrape every millimeter that you wish to and remove. So that is one of the advantages. The other advantage is a separation of the flavum from the bone bed. I think I've concluded this talk on the basic instruments that we use in UB. So I will shut it now, and now we'll go to some more interesting talks. So, like we said, we will start from the cervical spine, and I hope to make you enjoy this now because it's got a few videos, little content. So let's hope you enjoy this talk. What are my indications and what are my principles for doing this surgery? Basic indication lies that I use it only in paracentral disc herniations, never in a central disc herniation. For disc osteophyte complexes that cause in the posterolateral corners, that cause outlet narrowing for the exiting nerve roots. We have a Kim's classification on exiting nerve roots. And over there, it's only in grade 2 where there is more than 50% narrowing of the root at its entry and exit point that we take the call of doing a foraminotomy. I use this UB very effectively in single and multiple levels of cervical myelopathy, especially where I see that there is a lot of anterior osteophytes. It's a rigid neck. It may be K-line negative or maybe even in the K-line gray zone, but not a K-line positive neck. So what do I do over there? I do sequential hemilaminectomies or I do a complete laminectomy, but I keep the nuchal ligament intact. I keep the interspinous nuchal ligament also intact. So I do not lose the cranial spring. Therefore, the advantage in UB is that the patient doesn't land up with a swan neck deformity. Unlike Schofield's approach, in Schofield's approach, there is a lot of post-operative pain. UB, there is really no pain in the patients post-surgery. Scar pain is not there. I use it in pure posterolateral disc herniations, posterolateral osteophytes, causing foraminal stenosis, because it's a motion-preserving surgery. See, the world has woken up now to the problems of adjacent disc disease. So we touted fusion, but then after fusion came the problem after a few years, then again after a few years. So where you can use a floating tip technique, ensure that all posterior midline structures, muscle mass, all remains active. Patient wakes up post-surgery, starts moving the neck on day 1. We have a ERAS protocol when patient is up and about within 6 hours. We don't even use a cervical soft collar. It's only for the first 2 or 3 hours post-surgery when patient is groggy with anesthesia. After that, there's no cervical collar. We want immediate mobilization and neck movements to start naturally, and then gradually after a week to start the exercise protocol. I also use full endoscopic ACDF when I have an anterior cervical disc, which is right bang in the center. I will not go posteriorly. Either I will do an anterior cervical endoscopic discectomy, for which I use a 4 mm scope, or I will use a 10 mm stenoscope and I will do an endoscopic ACDF. So ACDF, yes, is a gold standard. Nothing changes there, but I do it endoscopically. That's all. I'm again hanging up. Just 1 minute, gentlemen. Oh, okay, fine. This is a little better. Something went wrong. Where is my screen? Screen shaking. No, can you see my screen, guys? Hello?
Yes, sir.
We can see
Yeah.
your desktop now.
Sorry, I think I lost my talk. Yeah, fine. So now let us see here. I've kept two images in front of you to show the area in which I do foraminotomy, wherein I cut into the IAP, I cut into the SAP, a little outside the zygoepiphyseal joint. Can you see the zygoepiphyseal upper joint? This is my landmark. The disc is between two zygoepiphyseal joints. The vertebral artery is outside it, and the vertebral artery is actually the floor of the nerve root. So, two things you have to remember, that the disc is always medial, as a matter of fact, under the central myelin by a millimeter or two. So you need to lift the axilla to enter the disc by a millimeter or two. Do not go vertically. This is the biggest problem that I see happening with monoportal endoscopic surgeons. I see them getting into trouble quite often because they tend to migrate vertically down by the side of the nerve root. And as a matter of fact, in between, there was a fad of trying to show, oh, I saw the vertebral artery. Why the hell you need to see the vertebral artery? Seeing the vertebral artery itself is a flaw in your surgery. It's not a matter of pride. It's a matter of stupidity. That you have gone down by the side of the nerve root, removed the tissues that were saving you to see a vertebral artery, and then you say, okay, I'm glad I didn't have a vertebral artery injury. It's a stupid thing to do, guys. Your disc is inside the zygoepiphyseal joints. You need to be making sure that your central myelin is gently lifted by a millimeter or two, and you have an oblique trajectory into your disc, nothing straight. So that is why I have kept this image for you all to understand this. As you come to the lower levels, the root is a little more shifted upwards. So therefore, you need to cut a little more of the IAP and a little less of the SAP to see the axilla and the shoulder. So you have to remember these small tips when you're doing this surgery. Why am I having this problem? I don't understand this. Fine. Now, what is the position that I give my patient? If you see the slide very carefully, you will see that I made the neck of the patient horizontal. I don't like, in my initial years when I used to do monoportal surgery, I'm pretty good at that too. I used to do my monoportal surgery like this. One day I had a crick in my back and I started wondering, what the hell am I doing, Malcolm? I need to be upright. Surgery is supposed to be ergonomic. It's supposed to be comfortable. So we started jackknifing our patients, bringing their neck up horizontal to the ground. So therefore, there is a strap on the buttock of the patient to make sure the patient doesn't slip down. Adequate padding at the knee to again make sure the patient doesn't slip. The head end of the table is actually used to reverse and lock the knees in place. Shoulders gently pulled down. Head gently strapped in place with a cotton tape, not with a white elastoplast. So at the beginning of the procedure itself, you can see how nicely the neck is horizontal. Sorry. Yeah. I have marked over here the midline. Then I have marked the lateral facetal line, lateral mass line. From the upper lateral mass, I am triangulating, and from the lower lateral mass, I am triangulating onto the lamina itself. This surgery must start on the laminar bone itself. You never fire the plasma unless you are sure, 100% sure, you are sitting on bone. Now, why this? Is because the flavum at the lumbar level is 20 millimeters thick, but the flavum at the neck can be only 6 to 8 millimeters thick, and it can be sometimes missing in the midline. Now, if you're stupid and you start firing the plasma directly, you can actually go through the flavum, injure the central myelin before you even realize it. So make sure you triangulate on bone, clear on bone, target on bone, find the J spot, find the spot where the two laminas overlap, start your burring drilling over there, because moment you are at that V junction or the J spot or whatever word you want to call it, that is the point that you are actually outside the cervical column. Where the two lamina meet each other, it means you are beyond the zygoapophyseal joint. You are no longer on the central myelin. And therefore, when you enter, you need an oblique trajectory to enter inside, never a vertical trajectory. Because moment you open up that V spot and you start cutting outwards to see the root, you are already outside the cervical central column. You are in the territory of the vertebral artery. So you don't go down, you go medially down. You can see here I'm playing a small video. I'm burring away the IAP using a diamond burr. And below me is the superior or the inferior lateral mass, or the SAP, what you can see. And here finding that medial edge, I slowly strip that medial edge. Now I'm already, when I'm stripping at this medial edge, I'm outside the myelin. I'm onto the root, gradually using a 1 millimeter or a 2 millimeter kerrison. And what you see below is a bulging disc, which I use a 2 millimeter grasper to mobilize initially. It looks very big, but it's actually only a 2 millimeter grasper. And then with a regular disc punch, I am pulling out the fragment. But I will pause this video here. There are two things I want you to see. After I removed the disc, this traversing root came down. The central myelin came in place. The exiting root can be seen, but most importantly, you can see the pedicular corner. This is the pedicular corner. Always the inferior pedicular corner must be seen and must be probed to make sure that the root is free here. Only then can you be sure that you have done a proper stenosis release. This is a video of a disc surgery, I understand that. But when you are doing a foraminotomy, you must see this inferior pedicular corner and your probe must slide through there. Moment your probe slides through there, you are assured, you're guaranteed, yes, my nerve root is completely free. So I will continue with the playing of this video. And at the end of the surgery, you can see how nicely everything is settled down along the pedicular corners. So that means my decompression was complete. Now you can, with UB, you can do 2 foraminotomies through a single set of skin incision. It doesn't really need any big scientific skill. You just need to squeeze the lateral mass distance, and you're skipping one lateral mass. But you can, with the 30 degrees, very nicely.
We're skipping up still right now.
You can see this nerve root also pulsating nicely, central myelin over here. So you can, with just one set of incisions, you can free 2 nerve roots. Now, see this particular case. Here I had a 67-year-old male with cervical myelopathy, multi-root involvement, stenosis on both sides at 4-5, 5-6, and 6-7. Massive claws anteriorly. You can see that the K line is little kyphotic, but it's in the gray zone. So now what to do for this patient? So we decided to do a floating tip technique, and you can see here the tips are floating at 3 levels. So the nuchal ligament is completely intact, the muscle mass is intact, and you can see that I've done foraminotomy at 6 levels. 1, 2, 3, 4, 5, and 6. First, I did on the left, then I did the surgery on the right. So, step ladder hemilaminectomy and releasing of all 6 foramens. See the post-op at 18 months. I'm having a fusion occurring over here. This is the pre-op, this is the post-op. You can see the fusion has occurred at this level. This facet joint has got fused. These bony claws have got fused. There is no progression of the K-line at 18 months. And at 18 months, again, I can see here in the CT scan the fused lateral masses. And you can see the floating tips everywhere. So basically, this patient recovered from a very bad myelopathy. He's gone back to his job. And that was a very surprising recovery because normally myelopathy, you do not see so much of recovery. You only get a 1 or 2 grade improvement, but this patient literally had 7, 8 grade improvement. So it was amazing to find this kind of a result. Yeah, what happened? Yeah. Now you ask me, how do I do the hemilaminectomy? See that I have done what I've done. I've freed the nerve root. I have to still do it. There is a small part left to be done. But you can see how nice and clean the vision is. You can go down, you can explore the nerve root. You can see the nerve root falling away. It's starting to pulsate. And then this was the other one. Skipping across the lamina, you can see this one, and there is one more over here now. We'll come to the next one. Yeah. And having freed both the roots, now I'm using a small dissector, gradually get an entry into the central area. And then I will use a kerrison to do a hemilaminectomy. Slowly bite through the lamina. Remove the lamina first, the lower part, connect the 2 roots, then the central part, and then gradually remove everything. So this is cutting through the whole lamina. And we'll go to the next video and you can see that. Now I'm removing the lower part of the hemilaminectomy. You can see the central myelon beautiful, the cord pulsating, all the tissues over there, the phlebectomy being done, and this central tip being kept intact, on which the nuchal ligament and the nuchal ligaments and the intermediate and the posterior nuchal ligaments all are on this tip. So a hemilaminectomy and 2 roots freed in one surgical setting. Phleum is removed from, let us say, C3 down to C5. You can even partially cut those laminas also to expand your hemilaminectomy. Now, if you were to do a laminoplasty and you do a hinge, obviously the hinge lifts on one side, but on the other side where it is actually hinging, there's very little really shifting or gaining of any space by the cord. So therefore, sequential hemilaminectomies was my concept, and apparently it's been working well in my short series of patients. When we have published this as one, this particular case as a case report, but we'll be coming out with our series publication. Now, many times when we were doing endoscopy, we realized, okay, why not we go over the top and even do a cervical foraminotomy on the opposite side. So you can see here in this video, I'm going over the top and I'm doing the foraminotomy, keeping the phleum intact. Then I'm stripping the phleum en masse, slowly completing the foraminotomy on the opposite side. You can see how nicely I've gone through, creating more and more space. I'm jumping the videos a little bit so that I can show you more. This is my side where I've opened up the root, the foraminotomy. This is part of the lamina which is cut, so you can see the curvature. And this is the going towards the axillary side. So opening up on both sides, 2 roots, everything being done, and over the top decompression being done. This is the over the top decompression. You can see that from one side, we have gone over the top and we have entered into the opposite root canal. Pedicular osteotomy. Sometimes when I see that the root is plastered, I have no space at the shoulder or axilla, and I need a more lateral or an angled entry into the cervical disc, I do an oblique cutting of the pedicle. And that helps me to gain entry with where even a 1 millimeter kerrison sometimes is difficult to put, especially when there is adhesion or plastering of a cervical root. So enjoy this video. This was done by me live in the fourth World Congress. And you can see that how tight it is. I'm not able to even introduce a 1.5 meter ball tip hook inside. The root is badly plastered over here. So what I'm doing is I'm cutting this pedicle in an oblique manner. Now, once I do this pedicular osteotomy, I'll be able to get underneath the root comfortably, strip the root comfortably, free the patient's root, which is badly adherent to the disc below. So now I'm able to introduce a kerrison slowly. You can see how tight it is, horrible it is. Bottom line is, yes, we've cut away a part of the pedicle, we've created space. You can see the axilla over here nicely, and I'm using a very fine plasma wand, which we spoke of earlier. I'm able to cut away those tissues which are tethering this root down to the discal surface and is the source of the patient's pain. So you can mobilize, you can free the nerve root slowly and gradually, making sure I can go around this particular corner here and making sure that my root is completely free from all entrapment. So now you can see how nicely we have mobilized this root gradually away from that particular undersurface. And I hope you enjoyed this particular osteotomy video. Let us come to ACDF. In my initial years, I used to do ACDF using a standalone peak cage. You can see my hook over here, feeling the osteophyte, probing the lower osteophyte in the disc, going inside, cleaning up everything. You can see that I'm between the two bones over here. I'm removing the last of the herniated fragment, pulling it into the canal in between the two bones, out from the canal, sorry. And slowly, after that, using a flexi-tip diamond burr to create just about adequate space. I need more space to put in a cage. I need more flattened bones. So I use a burr. And finally, a little bit of a kerrison. You can see the strap muscles on both the sides. And finally, you can see the pulsating dura over here, retained PLL. There's a little bleeding coming from this corner, but we will ignore it. And finally, we introduce a cage with a scope directly. But this cage is not properly positioned. I feel it's a little twisted towards my side, so I will re-engage the cage. And I made it more vertical. These are the paraspinal muscles. You can see them very nicely. And finally, realigning the cage in a more vertical central manner. So that was ACDF for you. See this patient, she had an instability at C5 over C6, large central disc bulge, instability and a central disc bulge over here. You can see how we first put in by shifting the trachea away. Over here, you can see there is a needle that I put in as a guiding thing. Then on the guide wire, I put in serial dilators. And finally, I put in my tube, working tube, remove the guide wire out. And this is the herniated fragment coming out, the bad disc that was inside. And finally going down slowly, slowly, towards the canal, expanding my zone over there by burring, cleaning, cutting out the posterior osteophytes, keeping part of the phlegm, PLL intact, partly seeing the dura over there, the cord nicely pulsating in the water column, and then finally fixing it with a cage. Cage is slightly a little to my liking, a tad bit on the other side. That's because in scopy we tend to angulate. Needs more correction, but what it is, so it is. And you can see that the cage is a standalone cage flush with the anterior cortex, nicely put in. Patient is doing well, and I hope she fuses well. So endoscopy allows you to do a lot of things. Now you see this patient in which I've done a 360-degree endoscopy. At 4-5, I needed a foraminotomy, and 5-6, I needed an anterior discectomy because there's a central anterior disc that needed to be addressed. So this is the foraminotomy being done from behind. This is the root which is completely free at 4-5. Shoulder, axilla, everything seen. And a little bit of phlebectomy to add to the spice. And then a central cannula right in the center. Turn the cannula to open up the PLL wedge and removing the final fragment out. And there is a pulsating central myelon. You can see how the PLL is opening up. So you can do a multiple combination of things as far as cervical endoscopy is concerned. Anteriorly, either a discectomy or an ACDF, but both the scopes are different. So the take-home message as far as cervical spine endoscopy is concerned is that UBE is the latest form of spine endoscopy to evolve. It's low cost yet effective. It's versatile. Most of your spine instruments you already have. And it has a very easy and a very smooth, short learning curve. Read my book. Sometimes, even if I stand in the middle of the room, no one acknowledges me. So that's how it was. It's no longer like that.